This is going to be kind of a whirlwind tour. I've got a really quick, I don't think it's been a while since we've had a good general summary of preventive cardiology and some of the updates of the clinical trials, updates of what we do clinically. Sandy Oberman is here. Donna Skoog is here. We all see patients that will be outlined, a few outlined in this talk, but talk about where we are in the United States and some of the risk assessment tool updates, statins, non-HDL cholesterol, the metabolic syndrome. We've been asked about the NMR profile and how to use that, and then talk about maybe where our program is headed. So just as a review, we're doing pretty well. Since 1968, we've cut the age-adjusted rates of mortality in the United States from 542 per 100,000 to 266 per 100,000. And that's primarily, and I'll show you what's accountable for that, but that's primarily due to the prevalence of smoking, hyperlipidemia, and hypertension going down in the country. In fact, almost half, or not quite half. But obesity, and as a result, diabetes are going up. So there's kind of this battle between these risk factors and these risk factors in the country. Minnesota is ranking #1 nationally in the CVD death rates right now. However, the obesity trend is hit. We're one of 33 states that are a quarter of the population is obese. Obese is a BMI greater than 30. And I'll get into that a little bit. However, the prevalence of cardiovascular disease remains high and actually is going up a little because the population is getting bigger. This is a study called the IMPACT study that you may have seen. And I noticed there's no interventional cardiologists here. But they looked at what caused the decrease in death rates. And it's a very interesting article if you want to take a look at it. They tried to account for this decrease very specifically. And they determined that about half of the reduction was due to the treatments of coronary artery disease, treatment of unstable angina, secondary prevention, again, medical therapy, treatments for MI and CHF, and attributed only 5% of that decrease to revascularization, and another half due to changes in risk factors that I mentioned. And that was offset by increases in diabetes and obesity. So you can see if diabetes and obesity were under control, this decrease would be about 2/3 if you add in the secondary prevention medical therapy. Medical therapy, preventing risk factors, treating risk factors, identifying risk factors, identifying those at risk is really the mainstay explaining this decrease, not catheters per se. Hypertension, despite being the easiest to diagnose and treat, remains the #1 visit to the healthcare provider and is responsible for more deaths, probably because of its relationship with stroke. The definition being greater than 140/90, and the top number, the systolic, being better predictor than the bottom number. We have about 1/3 of the population with hyperlipidemia or a total cholesterol greater than 200. More women have high cholesterol than men, and this is something I'm going to show you. The adolescents are now becoming obese. The adolescents now have hyperlipidemia. 10% of U.S. adolescents have a total cholesterol greater than 200. And then we have a recognition and treatment problem. Half of the people who are qualifying for lipid therapy are getting it, and 1/3 who need it are achieving their goals. So we've got a lot of work to do. And then obesity, not just a problem in the United States, it's a worldwide problem. We have 2/3 of our adult population either overweight, which is 25 to 30, or obese, greater than 30. And then again, adolescents, 1/3 being overweight or obese. This dramatic yearly increases. This is the one thing that continues to go up. Here's an interventional cardiologist. Do you want me to go back 2 slides? I won't. And in particular, we want to focus on the abdominal obesity because abdominal obesity is a stronger risk factor than just overall BMI, and I'm going to show you why. Here are those trends in graphic form and just graphing colors with percent of the population in 1990, 99, and 2009 that are obese. You can see here's Minnesota went from around 10% up to the yellow, 20 to 24, but in the East, South, and West Virginia, you've got 1/3 of the population obese. And as a result, diabetes kind of mirroring that. And why is that important? Well, if you plot cardiovascular mortality and overall mortality, it goes right with this BMI and this abdominal girth. As soon as you hit 25, you start to see an increase. And then when you hit 30, a real dramatic increase in mortality. And what we do in the clinic is usually we calculate BMI on everybody. We put them on this graph and we show it to them. So here's the graph, and you're right here. And we make realistic goals. You know, you need to be down to 29 by the time you get back. And that's a way to objectify weight and just say, don't lose weight. I want you to be here. And why is this abdominal obesity pattern so bad? And here's that apple shape. Remember, it's not the pear shape. There's this. The pear shape is, you know, this shape where you kind of have your hip weight. It's the apple shape that causes the insulin resistance and it results in increasing fatty acids, free fatty acids to the liver. So your triglycerides go up and your ApoB, remember ApoB for bad, that's the bad lipoprotein, and your VLDL goes up. That drives this reaction. And remember the CETP inhibitors, I'm going to talk about those. The CETP inhibitors are trying to inhibit this reaction, which is exchanging a triglyceride for cholesterol ester. What does that do? It makes your HDL and your LDLs really small, and the small HDL loses its ApoA1. The A1 is the protective lipoprotein, and then it gets excreted in the kidney. So the HDLs drop because you're urinating out your HDL. That's why they're low. In addition, you know, many metabolic syndrome patients don't exercise. And then you get this small type B pattern LDL, and I'm going to talk about that. But this reaction is key in this syndrome. So we know the metabolic syndrome, but just to review, the triglycerides go up, the HDL is low, it's male and female adjusted, and then it's central obesity. But if you have a BMI greater than 30, you can pretty much assume you've got central obesity. Not that much, though. Waist measurement of greater than 35 in women and 40 in men is where you get this metabolically active middle fat. It's not the same as the fat down here. This is metabolically active fat doing things. It's pushing that reaction. Your blood pressure starts to creep up, and as Sandy and I have seen multiple times, the fasting sugars go from 98 to 105 to 112 to 140, and then they're diabetic. This syndrome, and the ATP3 is going to turn into ATP4 next year, increases cardiovascular risk by 2,000. They're going to have to recognize this a little bit more aggressively than they have in the past. But right now, the treatment is very medical, it is not medical. It is very lifestyle-based. So here's a 58-year-old who meets that criteria on the waist size. Blood pressure is not up there yet, but it will be. The fasting sugar is, so they're insulin resistant. The LDL is low, HDL is low, like you might expect. The triglycerides are going up. Framingham risk score is 13%. So what would be the best approach? And this is kind of a trick question because I'm trying to trick you into giving some medication. It's really this diet and exercise program, and it's kind of hard to do. But this syndrome really responds to lifestyle. We've had some really dramatic changes with moving the abdominal girth. Not even so much the weight so much, but moving the weight from here to muscle up here. Changing weight and the weight distribution is the key. Remember, these people do have more atherogenic LDL. They're small and dense. Their HDLs drop. The dietitians see them, and we put these patients on this Mediterranean, if it came out of the ground or fell out of a tree kind of diet, around 1,200 to 1,500 calories per day. We tell people if you eat 500 calories less per day, which really isn't that much, you'll lose a pound a week. So if they're coming back in 12 weeks, we want you 12 pounds lighter. Exercise is key, and I'll talk about that, and setting these expectations. Then they move from the dysmetabolic syndrome into full diabetes. There's another group that's sort of genetically predisposed, but most of the patients are going to be obese. Remember, once you get diabetes, you now have a risk equivalent in ATP3. So they have the similar rates of disease as the patients with clinical MI. That's about 2 to 4% or 20 to 40% at 10 years. And you treat them to the secondary prevention guidelines. Diabetics die of cardiovascular disease, 3/4 of them. So we need to do a better job in this group. And interesting, look at the incidence of diabetes is varying with those obese geographic location that I showed. Minnesota being 6%, and this is all people, so the number's kind of low. It's not adults. 6% versus 12% in West Virginia. But here's an interesting issue to summarize kind of where we are. Here's the prevalence of meeting at least 5 ideal cardiovascular health criteria. So optimal blood pressure, optimal cholesterol, ideal body weight. All adults in the United States, 18%. And the minority is less than that. And here's a disturbing one. Childhood, adolescents, 12 to 19 years old, half. So we're really on a collision course. And in summary, I think to wrap up that first part, we're winning the battle but losing the overall war, particularly in the central obesity issue. So let's talk just a brief update on risk estimation tools. Yogi Berra was right. It certainly is hard to make predictions, especially when it's about the future. And I think that points out a good limitation to these risk estimators. And this continues to be worked on. There's multiple ones. I'm not going to go through all these. We've had calcium scoring talks. But basically, you've got your Framingham and your Reynolds and other risk calculators. You've got areas to detect subclinical atherosclerosis, either in the carotid or the heart, calcium scoring or CIMT. Mayo Clinic is doing a lot of genetic testing, looking for markers. Novel serum markers, the biggest being CRP, but there's multiple. There's fibrinogen, there's multiple others. And then this endovascular reactivity testing that they do at the Rasmussen. The risk scores, I want to talk about the risk scores because Yogi Berra was really correct on these. So Framingham is age, sex, cholesterol, HDL, smoking, and hypertension. You can get it online. The Reynolds now adds CRP and family history in the Reynolds score, so it might be a little bit better. Interesting, neither of these account for the metabolic syndrome or BMI. So you have to imagine data that was pulled out of the East Coast in the 70s, back when the country looked all blue like that, like I showed, may not be very valid in today's era. Here's a good example of how the Framingham risk scores are too age dependent. Here's a 75-year-old male with an LDL of 101, HDL is good, above 40, blood pressure is good, doesn't smoke, has a normal blood sugar, 10-year Framingham risk 18%. Here's a 34-year-old female with an LDL of 200, an HDL of low, the metabolic syndrome, blood pressure is creeping up, blood sugar is up, smoking. The 10-year Framingham risk is 7. And the reason I'm showing you that is because Framingham risk really underestimates long-term risk. It's only a 10-year number. So if you're 34 years old, it's almost always low no matter what you do. And there's 30-year risk Framingham. There's other risk calculators out there. But we need to look at those and understand what it's telling us and not just take the number and send people out the door. So what do we have to augment some of those risk calculators? We have CAC, we have CIMT, CRP, and if we get these high-risk results, high calcium scores in the high percentiles, a lot of CIMT greater than 0.7, a high CRP, we can then up-classify people into the high-risk groups. The risk prediction on these, the calcium score is more predictive than the CIMT, which is more than the CRP. Just putting those into relation, it's about calcium scores 5 times as more predictive as a CRP and twice as a CIMT. So here it is. I'm not going to talk a lot about this, but you've seen these many times. Coronary calcification, who really benefits? And I just want to show one study on calcium that people probably have seen, but this is such a good study that I want to review it. The MESA study. So NIH-funded, no industry influence, blinded, multiple institutions, 6,000 men and women, multiple ethnic groups, followed for 4 years, heart events only, not revascularization, coronary calcium, greater than 300, risk ratio almost 7, any coronary event almost 10. So here are the curves. If you have any calcification, you can see the events starting to occur early on, and if you're in this 300 group, you know, that's a high-risk group. There's no doubt about that. The MESA study really nailed that for us. If you have a calcium score greater than 300, you deserve to be in that high-risk group. So here's Jupiter. You probably have heard about Jupiter too, but just to remember, these patients did not have coronary disease, and they're not having a seizure. I think that's this. Men greater than 50, women greater than 60, good LDLs. In fact, the mean LDL in this group is 104. Good HDL. The HDL mean almost 50, but had CRPs that averaged around 4. A lot of people, 12,000 people, either got Residual, Crestor, or placebo, and it was a hard endpoint, although they did include revascularization. 4-week trial run-in, what happened? Well, if you were in the Crestor arm, you did a lot better. And why isn't that showing up there? It's cutting it off. there's a 44% reduction compared to placebo, NNT, or number needed to treat 25. Very small p-value. Look at the curves. They start diverging very early, within 6 months, a year, out to 4 years. So if you have these criteria, it's made its way into the recommendations, and these are the recommendations. So this group looked at everything. They looked at fibrinogen. They looked at every genetic marker. They looked at everything, and they came up with about 3 things that look like they can make it into the 2A recommendation, and these are them. They mirrored the Jupiter and said if you're a male greater than 60 or a woman greater than 60, you have an LDL less than 130, and you don't have clinical disease, and your CRP is elevated, or you can check a CRP. That's a 2A. That's Jupiter made it. CIMT, they basically said if you're intermediate risk, and similarly, if your calcium score, if you're intermediate risk. That's Framingham 10 to 20. Also for diabetes, recommended a calcium score for diabetics 40 or older. Look for subclinical disease. What we do here is we do calcium scoring in males or women that are above 55, in that range, 50 to 60. And we're starting a CIMT program for females, so we don't have to give them radiation if they're intermediate risk. And Stanley and I are just getting that going, hopefully within the next couple of weeks. And then if you don't have access to any imaging, a CIMT, realizing this is probably the weakest predictor. These two are stronger. This is the strongest. The calcium scoring is the strongest, stronger than CIMT and CRP. So, but it's just what do you have at your institution? What do you have available for you? And what does your patient need? So this is, I'm not going to go through this, but this is ATP3. And just to show you how complicated ATP3 is. They need to go back, and it's coming back next year, simplify this. It really is complicated. You know, you have to calculate the number of risk factors and then adjust your treatment based on the number of risk factors. If they have 2 risk factors, then you have to do the Framingham risk, then you put it in these buckets, and then, you know, you've got all of these risk equivalents. So it's pretty complicated. I simplified it here and added a little bit of what we do. So this is pretty much what we do. You look out of the gate for risk equivalents. You look for coronary disease, peripheral vascular disease, diabetes, even without CVD, or the high Framingham risk group. That's the high risk group. We treat to an LDL of less than 100 and prefer less than 70. And I'll show you why we prefer less than 70. And if there are 1 or 2 risk factors, we calculate Framingham risk. And if you get this intermediate risk group, look and see what your patient might be able to tolerate. A 60-year-old man, I might recommend a calcium score. 45-year-old female, maybe a CIMT or a CRP. Identify that metabolic syndrome. FOD BMI, look at their fasting sugars. You'll see them start to creep up. And then really talk about BMI, show that goal, and try to work on that. The blood sugars will come right down. The blood pressure will come down. We can get people off medical management. And then here's an important one I'm going to talk about, non-HDL cholesterol goal. This non-HDL cholesterol goal gets neglected. Particularly, it should be calculated when the triglycerides are greater than 200. People tend to not do that. And the non-HDL cholesterol goal is 30 more than the LDL goal. So the non-HDL cholesterol represents all of the ApoB lipoproteins. All the lipoproteins that have B, the bad lipoprotein. Or you could measure ApoB, like in Canada they measure ApoB. In Europe, in studies, they sometimes measure ApoB. This is a good surrogate for ApoB. So when the triglycerides are greater than 200, the secondary goal is this non-HDL cholesterol. And why did I talk about 70 as opposed to 100? You've probably seen this, the 2006 update based on the TNT data and others, that it's a reasonable goal for all patients with CHD to achieve 70. And if you can't, you should go for a 50% reduction. So either a 50% reduction or less than 70 in the highest risk group. This is the secondary, and I don't have a lot of slides on secondary prevention because I think we know that fairly well, but this is a little bit of the HMG CoA reductase inhibitor data on secondary prevention. And 2 things to note: statins, always better than the placebo; lower, always better than higher. And in fact, people often ask, well, what should my LDL really be? You know, that goal right now on ATP3 is 70. But here's the PROVE-IT data. Remember, PROVE-IT was intense LDL lowering versus modest LDL lowering. And they looked at a subgroup there using this 80 to 100 as a reference. It continues to do better the lower it goes. And umbilical cord blood LDL being about 32 to 38, it looks like, we don't need much after 40. And the LDL goal in the guidelines will continue to come down with time and probably end up somewhere around here. So here's just a cumulative impact of these secondary preventive medical therapies. And you take somebody who has a high cardiovascular risk, who's had an event, who walks out of here after having an angioplasty with a 2-year event rate of 20%. You add aspirin, beta blockade, ACE inhibition, particularly with a low EF, lipid lowering, and then you get that lipid lowering from 100 to 70. You've turned their event rate from 20% into 5%, and an NNT of 6. So this kind of program, we need to make sure all of our patients are getting this. Unfortunately, they go back to Hutchinson, or then, I don't want to pick on Hutchinson, but they might go back to their hometown, and this ball gets dropped. So they should have at least one visit with us in the preventive clinic to make sure we're hitting all of these markers, because if you only get 1 or 2 of them, you really haven't given them this potential 75% cumulative risk reduction. You might have given them more like a 10 or 20. We get asked about non-pharmacologic therapy. I was impressed when I did the research on the fish oils. Secondary prevention, gifiprovenzone, and here's an interesting thing. It has to be a milligram of DHA EPA, not a milligram or 1,000 milligrams. That's a gram. 1,000 milligrams of it's omega-3 fatty acid. And you really have to have that formula, and I'll talk a little bit about that. Reduced cardiac mortality significantly. In the heart failure patients, the same thing. A gram of DHA EPA reduced all-cause mortality by 9%. This is a Asian study, the GELIS. They used 1.8 grams of EPA, omega-3, to benefit both primary and secondary 19%. We tend to use the Lavazza. It's a little bit costlier. Very effective at lowering triglycerides, probably more effective than gemfibrozil in some circumstances. So getting the right formulation of omega-3 in your fatty acids. And here's the AHA recommendations: reducing sudden death, lowering triglycerides, anti-inflammatory, antithrombotic, improving endothelial function. AHA says if you don't have cardiovascular disease, you should eat fish. I'm not so sure about that because the soft tissue carries the mercury. The fish oil tablets don't. So if you're pregnant, you can have fish oil tablets, and you can't eat the fish. But you can have 500 milligrams of EPA, DHA, or if you have cardiovascular disease, at least a gram of the omega-3. And then in these high triglyceride patients, you'd be surprised. You can give 6 to 8 grams a day of this stuff, and I had a patient's triglycerides go from 800 to 250 with Lavazza, with 2 Lavazzas alone, which is 2,000 milligrams of omega-3. That stuff works. One quick mention about exercise. You can plot in any study cardiovascular risk, almost any mortality, any outcome you want, and exercise, and it's going to show a direct relationship. But people often ask, well, how far should I go, or what should I do? We just recommend 150 minutes per week is the AHA recommendation. Take 220 minus your age, and then you want to be 60 to 80%. I usually pick 80, so for a 65-year-old male, you do 220 minus 65, 155, multiply it by either 0.6 or 0.8, and you'd say get your heart rate around there. Just a rough tool you can use to tell people what to do. Now I'm going to talk about a patient that we've seen all the time, and this is your statin intolerant or your achy patient. Here's a 60-year-old male who's had an infarct in 2008. He comes in achy. And he's a former smoker, so he's got additional risk. His BMI is a little bit elevated. He exercises occasionally. He's on Lipitor 40 and fish oils, not 1,000 of DHA EPA. Fish oils a gram a day. And here's his total cholesterol, 141, LDL, looking pretty good, 69, triglycerides, 220, HDL 28. The CPK is normal. So what's the next best option? Anybody want to shout something out? Do we reduce the Lipitor dose? Do we stop it and start Zocor and add CoQ? Do we stop it at Crestor and add CoQ, or do we start a fibrate? We can do that. I'll talk about that. But that's not my first thought. I know vitamin D is important, but it's not my first thought. C, I think it would be a good choice, and I'll tell you why. First you want to do is look at his LDL goal. Well, we've determined him to be in this category, CVD with additional risk. This 70 goal looking like the best goal for him. And, I think you're dealing with a guy with statin intolerance and secondary prevention. What are some of the tricks and tools? The myalgias right now are the leading cause of statin discontinuation. We need to do a better job at this. What's happening is these patients are coming off of their statins, and then it's done forever. They've tried 20 of something, they had some aching, and it's done, and they've just doubled or tripled their cardiovascular risk. So take a proper history. Are they having fibromyalgia or osteoarthritis? Check a TSH because that increases their risk. Look for medication interactions, and I'm going to show you which ones. Remember that the CPK, remember this guy's CPK was normal. It doesn't have to be elevated to have this statin intolerance problem. So it's important to remember that there are two classes and two elimination pathways for statins. Lipitor, Zocor, and lovastatin are in the CYP 384 elimination. These are lipophilic. They like to be with the fat. These are the ones where you're going to get the interactions that came out from simvastatin and the multiple drug interactions. That's not the case with Crestor, Pravachol, and Fluva or Lescol. These are hydrophilic. They may also have slightly less CNS effect because they're not lipophilic. Remember, don't combine gemfibrozole with any of these drugs. If you need a fibrate, use phenylfibrate. And the myth of grapefruit juice is that if you take a statin at night with one glass of grapefruit juice in the morning, it has minimal effects. You really have to drink about a quart a day of grapefruit juice in those studies. So that's overplayed with the people who like to have their grapefruit juice down in Florida. They can do that. Here's the Simva 2011. This came out. I think I sent it out to the group. Nobody can really start the 80 milligram dose anymore. You can only stay on it if you've been taking it 12 months and you've had your LFTs and everything monitored and you're feeling well. You can't be more than 20 milligrams with Norvasc and ranolazine. You can't be more than 10 with Amneal, Verapamil, and Tilt. And you can't use it at all with any of the Zol drugs or HIV drugs or Mycin drugs, Fibrozil. This may start to creep into other drugs in that lipophilic class. So your initial strategy ought to change classes. That's why C was the correct answer, to move you over to the Crestor. However, if you're in renal failure, we do favor Lipitor because it's not renally excreted. Otherwise, we favor the hydrophilic statins for these myalgia patients, the Prava, Rasuva, Lescol. And remember, you're going to get your best LDL lowering with a Corva 80 or Lipitor 80 and Crestor 40, about 60%. You want to continue to try alternates. We've gone through 5 drugs and then found one that people seem to tolerate, particularly if you do alternate day dosing. You should be dosed at night. People take this during the day. We make our cholesterol at night. That's when it should be taken. And the other thing we see is that people are holding statins as their LFTs start to creep up. You really don't need to do that until they get up into 3x normal or CPK 5x normal with symptoms. We have plenty of people in the clinic that we're following with ASTs of 110, 120, 80, and they just sort of stay there. They vary with exercise. Hydration seems to bring them down. So you don't have to be immediately stop. Getting the vitamin D, this is all I have. Sorry, Greg. But we do check vitamin D level and keep to a level greater than 60. Anecdotally, this kind of a supplement program really seems to help. If we have them take it at night with enough CoQ to replete their levels, the statins drop CoQ levels significantly. The studies that have looked at this really haven't given enough. They've given like 60 milligrams. The Mayo, I think, does 300 BID, TID. We're going to 300, 200 BID, TID on CoQ10. And then as we talked about the vitamin D level treating, if you do all of that, you'd be amazed how many people can tolerate one of these drugs. So I agree, and him, probably the best option is to try to move them out of the class. And what we see is a lot of people go from Zocor to Lipitor, for example. You're probably going to get the same kind of issue, or Lipitor going to Zocor, Lipitor or lovastatin. Zocor or lovastatin, you need to go over to a Pravachol or Crestor. So what would you do now? We increased him, and as mentioned, wanted to make sure you got 1,000 milligrams of the DHA EPA. We got him on the right amount of exercise. He's not aching. He comes back. Is looking pretty good. Total cholesterol 137, LDL 65, triglycerides maybe slightly elevated, HDL still a little low. Remember his BMI is 28. What would you do now? No changes were good. Add gemfibrozil, add fenofibrate, add niacin. For AMI, you'd add niacin. Okay, well, let's take a look at that. Remember, the non-HDL cholesterol goal when triglycerides are greater than 200. So we need to calculate that. Remember, the non-HDL cholesterol goal in this guy is going to be around 100, optimally less than 130, 100 on the triglyceride. So in him, he does have a slight but persistent elevation of that non-HDL goal. So you probably do want to consider the fact that statins do reduce cardiovascular risk. However, this is still a group with high residual cardiovascular risk. So you didn't prevent 70% of the events, 20% reductions, but you still have a risky group here. And what can we do better? Here's the TNT study. So really, this is really impressive because these are patients with an LDL less than 70 on a statin. And look what happens if your HDL is greater than 42 versus less than 37. It's almost doubling of the 5-year major CVD risk. You know, it's dramatic. There's significant residual risk with a low HDL. Like this guy was 30, his HDL was 30. So I'd like to get his HDL, if we could, up to 42 or higher. Same thing with triglycerides. This is the ProCam data. For any strata of LDL, you see a distinction between the greater than 200 and the less than 200 group. It gets even worse when you get into the high LDL groups. CHD cases per 1,000 in 8 years. So even at the low LDL groups, you have this strata. Remember, this non-HDL cholesterol goal, so it's very easy to do. You take the total, subtract the HDL. That's all your ApoB. You know, that's the LDL, that's all LDL, that's all the bad stuff. All the atherogenic lipoproteins are in there. This is commonly elevated in the metabolic syndrome. You almost always have this elevated. And your goal is going to be less than 30. So here we go, 137 by 107. We say, well, what can we do about it? Well, in particular, this guy with a low HDL, you've got niacin, fibrate, statins do some on HDL, omega-3 fatty acids, Zetia not so much. But I'm going to talk a little bit about niacin because we get asked this a lot. The over-the-counter niacin is not nicotinic acid. It's inositol nicotinate. And some of them don't work at all. Some of them, and that's one of the reasons they don't flush, is because they don't work. Niacin gets metabolized, the real niacin, the nicotinic acid, on two pathways. There's this high-capacity pathway that causes the flushing, and a low-capacity pathway that doesn't flush but gives you more liver toxicity. That's the trade-off. So slow, controlled, sustained, long release, these give you reduced flushing at the expense of LFT elevation. Niacin on the high-capacity pathway, but a slow-release formulation, slows metabolism, but not so much, is to markedly increase. And this is the one we use a fair amount, Niaspan ER. You can avoid the flushing by taking an aspirin 30 minutes prior. I tell people, sit down for dinner, take your aspirin, eat for breakfast, and then take your niacin. This promotes large, buoyant LDLs, and I'm going to show you a little bit about that. But that's what we want. We want larger, less atherogenic. You do get modest increases in glucose. So if you start on niacin, almost anybody, I think you should be monitoring glucose. We don't monitor uric acid levels, but we do monitor glucose levels. So what is the data on before AIM high? What is the data on niacin? It was very impressive. The Coronary Drug Project, this is prior to statins, niacin alone, a gram TID, a lot of it. You know, significant reductions in hard endpoints in this group. And in fact, a mortality benefit of 4% at 15 years. They followed out a long time. Then when we start looking at the CIMT studies, so these are kind of the surrogate studies, you add niacin to a statin, versus a placebo. It did better at 12-month progression of carotid IMT thickness. And in clinical follow-up, ARBITRA-2, same study, a significant 60% reduction in events in this group. But it was a very small study and wasn't really powered up to do that. But that prompted aim high. So, and then ARBITRA-6 is another carotid study. I wanted to put this in here because these are patients on a statin who take niacin, 2,000 milligrams of Zetia, and you can see that the niacin, had a reduction in carotid IMT and very little with the Zetia. MACE was actually lower in the niacin versus the Zetia group, and it was significant. So that led to aim high that Casey mentioned. Just came out of the AHA, so if you're there, it was one of the late-breaking trials. Here's the things that impressed me about this study. It's not very big. There's only 1,500 people in each arm, even though it's 90 centers. How do you do 90 centers and only 3,000 people? What does that come out to? I mean, just not a very big study. They had Simba to an LDL of less than 80 plus Niacin versus placebo, and they terminated it early. And it's too bad that they terminated it early, because I just pulled this off the AHA website where they protect the PDF file, and I unprotected it and copied it. I screen copied it. So you didn't see this. But this is what they showed 3 days ago. The primary endpoint, there was no difference. And the reason they stopped the study was because they saw more ischemic stroke in the niacin group. Only when they did the statistics on it, it wasn't significant. Now, if you have a bar way over here that looks like this, and it's not statistically significant, you've got kind of an underpowered study. So nothing was really falling out on the cardiovascular side because they didn't let it go long enough that it was small. And then they stopped it because of this, what turned out to be not significant. So it's unfortunate. But the good news is we have HPS2 Thrive. HPS2 Thrive is 25,000 patients. This is coming out in 2013 or so. They're taking niacin ER and they're adding this prostaglandin inhibitor so you don't get the flushing. And they're also going to monitor the glucose. So in AIM High, they didn't follow who got diabetes from their drug. And maybe that's why they got carotid medial thickening. And I'm going to mention one more thing about these studies at the end, my own personal thought on it. Fibrates, you've got two. You've got Tricor or Lipid, pretty much. Phenylfibrate has a lower risk of myopathy when combined with a statin than Lipid, and you get triglyceride lowering primarily. Lipid, 30% lowering. Lipid is a good drug for a familial type 4 or just an isolated triglyceride problem, but do not combine it with a statin. If you're going to use a fibrate with a statin, you want to use a phenylfibrate, either Tricor or the generic. What is the difference between the fibrate and the niacin? And this is something to keep in mind when you start using these drugs. So here's Gemfibrozil 1200, Niaspan 2000. HDL increase is going to be a little better with the niacin. You can get a paradoxical increase in LDL with the fibrates. You've got to watch that. We've seen that in the clinic. You're going to get more triglyceride lowering with the fibrates than the niacin. Niaspan is the only one that really gives you a 20% reduction in LPA. And remember, LPA is kind of this atherogenic little lipoprotein that tends to run in families, in particular women. We have a couple families where all the sisters have this, so their LP little A's are 150 to 200. So this is a good drug for them. So going back to some of the fibrate studies, this is again early stuff, pre-statin. The fibrates did very well. Here is Lipid versus placebo without a statin, reductions, 20% reductions in non-fatal MI, coronary heart disease, and stroke. Triglycerides came down. The LDL didn't go up with that group, but it can. Unfortunately, you've probably heard about the Accord. So this is just a composite endpoint on Accord where they added Tricor to the simvastatin, and they didn't see a benefit in that group. So this is 5,000 patients. They added Tricor to the statin. New England Journal just came out. So it's really interesting that you have this residual risk beyond LDL lowering, but you have these drugs that seem to treat that residual risk, but you're not seeing the clinical endpoints to go with it. Zetia enhanced the primary endpoint, looking at mean IMT, really didn't have an additional change in carotid IMT compared to Vytorin, and I think that's the problem with Zetia for me, is that most of the studies they've done, other than improve it, they've compared themselves in the combination with Stimba, and that's cheating, right? So you put your drug with Stimba in SHARP. So here's renal failure patients who reduced major events versus placebo, but it's a combo drug. Same thing in C's. They reduced events, but they did have a few more cancers with Vytorin. So the study we have now that we're waiting for is improve it. This is actually different. So this is Stimba-statin versus Vytorin. So you're going to be able to see if there's anything really additional to the Zetia. And they met. I know the guy who, Jim Stein, I think, these guys met, and they decided to extend the study. What does that mean? It probably didn't have a statistical difference, but this is what it looks like. Post-acute coronary syndromes, they're randomizing them to either Stimba or Vytorin, and then they're getting follow-up visits, and they're following them for 2.5 years. So we'll see what that shows. I think it'll tell us a little bit more about Zetia. Welcall, interesting medication because this is a bile acid sequestrant, and it gives you an additional LDL lowering of maybe 15% and a little bump in your HDL. It can paradoxically increase triglyceride levels. You've got to be careful on that. It's insoluble. It's not absorbed. The interesting thing is they haven't done any outcome trials, and I don't know that they're planning to. It's kind of a good strategy. Just lower the LDL and don't do the outcome trial, So we use a fair amount of Welcall when we need additional LDL lowering in the clinic, and it works very well. These are the CETP inhibitor studies. If you remember, this drug, Procitrabid, on the Illuminate study, costed Pfizer $800 million. It raised HDL. Remember the CETP pathway that I showed you? You inhibit that, you raise HDL by up to 100%. The problem with it is it killed people. 25% increase in death, 60% increase in all-cause mortality. And why might that have been? Well, one of the things it seemed to do was raise blood pressure and increase serum sodium and aldosterone stimulation and cortisol. So there are 2 new drugs that are being tested, and Tim, Henry, and I are trying to get us into this one. This is the Delcitrabid. It's a Genentech LaRoche drug that modestly increases HDL, and it doesn't upregulate the aldosterone. I think these drugs, there's another one, Ancitrabid, there's another one. These drugs have a lot of potential, and I wouldn't give up on them yet. So in 2006, and this didn't have AIM high, KC, but the group met and decided that in patients who are taking statins that have continued non-HDL cholesterol, combination therapy is recommended. And this is the guideline we continue to go off of. This has not been changed. AIM high hasn't changed any recommendations. It hasn't changed the FDA labeling of niacin. The preferred agent to use in combination with the statin is niacin because there's somewhat better evidence for event reduction. But we use, if the triglycerides are very high, we use fibrate too. So in him, I agree, you could add the niacin. So niacin was added. Since the last visit, he's continued to have events. Unfortunately, that's something that continues to happen, right? So here's a guy who continues to have cardiovascular events despite our best medical therapy. And here's his lipid profile, 131, 60, 150, 41. What could be considered? Anybody have any thoughts? No, we're good. Add a fibrate, a calcium score, or NMR. Yeah, so I wanted to introduce the last 5 minutes this NMR profiling. Who do we do it in and what it shows you? And why it's important. And this may be the problem with all of those studies I just showed you. They didn't take people who were at LDL goal and measure their LDL particle size and then randomize the ones with small dense LDL to treatment. They just took everybody. And we know that the small LDLs are much more atherogenic, more able to penetrate the arterial wall intima, and associated with progression. And here's just a clinical outcome of the associations between events and LDL particle numbers. So if you have a low LDL cholesterol, think of LDL cholesterol as a big bag of cholesterol, and the particles is how many LDL particles are in that bag and how small they are. If you have a low LDL cholesterol and a high particle number, you do just as bad as the people who have a high LDL cholesterol. That's impressive. And if you have a high LDL cholesterol but the particle number is low, you do as well as the people with a low LDL cholesterol. So this LDL particle, which represents the NMR spectroscopy size of the LDL, and then the total number of LDL, is an important number that we're probably not checking enough. And here's what they look like. This is just a sample. It doesn't look like that. It looks like that, though. This is what, if you order one, we tend to use LipoScience. There's 3 companies, without going into each, but they all have their pluses and minuses. But this is what they look like. The first thing they give you is the LDL particle number. And what you want there is less than 1,000. And then it'll tell you, are they low, moderate, high. And then the LDL cholesterol. So that's kind of what you measure in a regular assay. And your HDL cholesterol. And then the other thing to look at is they actually measure the NMR spectroscopy size of the LDL, and they tell you which pattern you have. So if it's a large LDL cholesterol, a large pattern greater than 22 nanometers, or is it small? And then they also do this IR resistance score based on the HDL. But for this guy, we're talking about these 3 things. That's what I would focus on. So in this guy, we did it. And we found out, interesting, even though his LDL cholesterol looked quite good and controlled, he actually had moderately increased particle numbers, and they were small. So there's a lot of small, residually atherogenic particles there. We titrated up his Niacin, which we mentioned makes those particles bigger, and got them down to 889 optimal and moved them to the type A pattern. We do this with multiple patients in the clinic. So in summary, statins are the mainstay right now in both primary and secondary prevention. You should achieve your LDL goals first before worrying about non-HDL cholesterol, Lp(a), or particle sizes. But when you get to LDL cholesterol, in particular to having events, these are the things you should start thinking about. If you need additional LDL lowering, you've got Welchol and Zetia. If you want to treat non-HDL cholesterol and particle sizes, you've got niacin, fish oils, and fibrates, particularly when their triglycerides are high. I just want to mention we've now signed up for AllCardio, which is our first phase 3 clinical trial this year. This is a study that we're going to look at. This is a dual PPAR gamma and beta agonist. So it's sort of like taking a fibrate and a glitazone and putting it together in acute coronary syndrome patients with type 2 diabetes. So we'll be recruiting people out of the cath lab up on the floors. Holly's here, and she's working with me, Des J, Mark Newell, Ferda. We're going to recruit patients in Brainerd to get this study up and running, and then hopefully we'll get one of the CTEP trials. I think that would be a good addition for us. And then where are we going? Well, I want to grow, and we want to do some of this at our new center. Abbott has bought West Health. We now own the whole building. We're looking at expanding in Edina and 212, but we want to do it right. And if you're going to do this, you can't dabble. You really got to understand the data and do it right. We are working at integration in the EHR, much like we're doing in HANU, developing a dashboard, a column-based dashboard that really tracks people and gives them some information on these kind of things. We're testing population-based strategies in New Ulm, introducing calcium scoring or other treatments for the intermediate risk group. They got a big intermediate risk group down there. And the events will continue unless we stratify them. We're looking to integrate into the service line. I've been going to those meetings at 6:30 in the morning, by the way. We've got Mike Miedema, who just signed on board, who's going to continue to help us with research. We have another lead on a physician who's very interested in population-based research. We're looking to bring that CIMT and integrate new technologies. This will be up and running. And then we've got AllCardio and others coming. So I think we've got a lot going on in prevention, and Sandy's here to help answer questions. She sees a lot of people and has been doing this a long time. So I think that's all I've got. I did have a little thing on lipoprotein(a) since people always ask about it. but it's a modified ApoB-LDL is what it is. That's what Lp(a) is, and it's both atherogenic and thrombogenic, and probably more thrombogenic than atherogenic. Autosomal dominant, and kind of difficult to treat, although if you use niacin and lifestyle, you can get significant changes. If you have somebody who's, say, 40 years old that has a really good-looking profile, particularly if it's a woman, you might want to check this because you'll find it's 160. So I think I'll stop, and I made it with 4 minutes to spare.
Really, really excellent. But I think it's worth everybody knowing here. Just to start, we're in the registry, called Transit, and we call, these are patients who are, volunteering to sign up. And it's 6 weeks across the country, about 70% of the people in this are cardiologists. And in our practice, only about 35% of the people with acute coronary syndrome, with only non-installation and installation of heart, have seen a cardiologist.
Yeah.
So the biggest thing we're not doing is we're not seeing them at all.
Yeah.
So we're not only are we not doing what we should be doing here, but that means 2/3 of our acute of mind are not seeing cardiologists.
We need to find a way to do that without sort of bogging down the outreach clinics, I think, with routine follow-ups. And I know we've got a nurse practitioner in Cambridge. We've got a nurse practitioner in Grantsburg. That model is something we really need to look at because I agree. If we send people back to their communities and they don't plug into those therapies, you're not doing them any favors. You really just put a Band-Aid on the disease. And I always tell people, Tim Henry didn't cure your disease by putting in that stent. Sorry, but he did not. You still have the disease, and in fact, you're at risk. So we want to treat the disease. We want to treat that underlying process. He fixed the at-risk lesion at that time, the acute lesion, the plaque rupture. What are we doing for the disease? And we can't just turn people over because we know it doesn't get done.
The number of screening studies looked at certain outcomes certain not around the country, this is urgent opinion about the presence of the push you into secondary category or severity of
well, when we look at MESA, when you look at that, that's why I showed MESA. When you look at MESA, it's very compelling. There's no other really single test that gives you a risk ratio between 6 and 10 for heart events. Certainly if you're greater than 300 and you've got subclinical coronary disease like that, I'm pushing everybody to less than 70, all of them. And I think that will come. It's who wants to sign up for that for that placebo-guided trial? No. That's never going to happen. If you sit there and wait for the randomized controlled trial on calcium scoring, for if it's greater than 300 or 0, randomizing the statin, and you want a lot of people, first of all, that'll never get passed. No IRB will ever let that go. Secondly, nobody will ever sign up for that study. So I don't think it's ever going to happen. And we're going to need to look at the data and say what we think is the right thing to do. It has made its way into a 2A recommendation. There's enough data there to compel the organizations to say that. That's probably as far as it's going to go. And, if it's greater than 300, if you have a lot of subclinical disease, you've gotten a 12 to 15-year lead time on the event. And it's time to act. Because that's the time between the clinical event and the onset of atherosclerosis. It's not 2 years. It's 12. So when you start seeing subclinical disease, you've got time to arrest that and prevent the event. Well, one thing, that you can do is look at the age-in-sex percentile if you're in those moderate ranges. So if it's 100 and you're 80 years old, that's a little different than if it's 100 and you're 35 or 40 years old and you've got a family history. Again, it's much like the Framingham risk scores. You need to put it in context in your brain and think about what makes sense. 100 isn't 100 for everybody. I think if you're 40 years old and your dad had an MI at 41, your score is 100, that's a high-risk patient. If you're 70 years old and your score is 100 and you're in the 38th percentile, that's a little less meaningful. So that percentile for age and sex number is the way to maybe put that in context. In terms of heart events, though, the absolute number is the one that really goes. Maybe not as aggressively if they're 75, yeah.
What about these patients who come in, could be a woman, someone started on statins for whatever reason, now she gets tough, you feel comfortable removing?
I do. Yeah. If you talk to Budoff, he's very interested in what the meaning of a calcium score of 0 is, but that's why they put it as a 2A recommendation in the diabetics. That was a big concern on calcium scoring for a lot of years, but a calcium score of 0 in a diabetic was a false negative. It's really not. A calcium score of 0, the event rate is 0.2%. And there are a few people, probably smoking diabetics, that are going to have an event. But in general, if you have a 0, they're not smoking, they're not a full-on, diabetic, that's a low-risk person, and we pull them off and save them a decade of lab tests, LFTs, therapy. We might check it again, depending on their age, or I might check something else. But, yeah, you can feel pretty good about it in terms of prognosis. A calcium score of 0 is going to be a better negative test than anything else we have right now.
Using this as a negative diet score, really expect to have nothing effect.
That's why the value is in that intermediate group, because if you get to 0, you can take them off the statin and say let's do some other things. If it's not, you can feel good about saying, hey, I know you're only 42, but your calcium score is 100, and I really think you need to press on. That's where we use it, and hopefully, the thing that worries me about calcium scoring is a little bit of the younger women and the breast radiation risk. So that's why we'd like to get the CIMT going for the 40, 45-year-old women.
Tell you that now with our current
yeah, it's not very big at all. It's a half a millisievert, so it's about 2 months of background radiation. Nonetheless, it's radiation. If we can do it with CIMT, you're not going to get any. And there's a vessel right here to look at. So we can look at this vessel very easily. It's very sensitive for the development of atherosclerosis. And exactly where it's going to play a role in our practice, we don't know, but we'd like to start using it and get it going. I think Kevin had a polypill idea, and there's a lot of polypill ideas. It just gets wrapped up in politics and cost, but the concept is very good, I think. And it depends what goes into the polypill, and do you take 3 things that are over the counter? Do you take a niacin, maybe a baby aspirin, vitamin D, and something else? I think that's not dead. It will probably come on. It's just, it becomes a cost issue. It becomes very political. But it's still being talked about. Does anybody else know things about the polypill, Rob? It's just
Grim was involved.
That had a blood pressure component in it. Yeah. Grim had one with a blood pressure component. I think they had in there. It's not a bad concept, just because there's such a lack of integration with healthcare.
And there may be some
economics. Greg?
Since you raised these of cost, one of the things that they confirmed is the dosing of CoQ10 is very expensive over the counter. And I'm wondering if there's any certain level of measure of oxidative stress that you would use in exercise. And the other concern I have is they're available now, and maybe that's access to that. The other concern is that CoQ10 is based on 2 different routes. Route number 1 uses vasodilate and solids. That's very cheap way to do it. Second route uses heat fermentation. That's the route to do it. They both are, regardless of what route you use, they all are high price. And so it's important to check the sources of those. Make sure that's probably not getting up.
Yeah, I hadn't looked at the cost, but I haven't had any patients complain about it, so I wasn't aware of that. But if you're interested, we have many patients that are on these doses. This is kind of what the Mayo's using. This is pretty common now on statin intolerance, so we should look at that. I'm not aware that anybody really has. There is some data, but I think they only use 60 or 100, and they weren't using the 200 and 300. But that'd be a great a thing to look at.
Yeah, the test 500 people I've tested, I tend to find that folks who tend surprisingly low and people off test, and then surprisingly normal on test. They also looked at the silence for the crop size and make that crop behavior. Those are measures by those.
This is more anecdotal that it works, you know, with the vitamin D. It does seem to work. It's not, you know, at that level.
So the question is very excellent. Going to take a look at the literature. There's some positive studies or college. Do you have any help from the average that knows anything that
No.
It doesn't, there's no indication that.
No, he means clinical outcome, though. Yeah.
There's no bottleneck in that. But obviously we need to turn levels really high.
Yeah. Can you order that assay here, Greg? Like if we just start ordering it? Okay. We can do that.
The other thing is that there are pre-randomized controlled trials on like status and statin intolerance trials. And prevention trials have shown that the same vitamin D trials. The whole of selected I have not been maybe
Well, everybody who gets put on a statin, their CoQ levels drop. So anybody on a statin is going to have a low level. Those are all low. Yeah. But if they're on statin, they won't be normal. They'll always be low. They all drop. So as soon as you put them on a statin, it's going to drop. A lot. I mean, this CoQ10, that's nobody really knows. I can tell you anecdotally that, you know, going that process that I showed you, we've been able to get 98% of the people who are statin intolerant referred to the clinic. These are people that have been tried on 2 or 3 drugs. What you think, Sandy? I mean, when was the last time we didn't get somebody on a drug? It's been a while.
I can review 100 milligrams a day. 50 gallons is photos. But I say I've been doing this now about 10 years. It's not easy. Can I just base it on whether symptoms are improved or not? If they don't, I probably
right. Yeah. But you're on your statin. Are you? Isn't it worth it, Casey? Anybody else?